This morning or the earlier sessions were absolutely amazing, and so was this morning. The third session, we're going to really focus on identifying key elements of integrated frameworks to guide our DEI efforts and well-being efforts to support leaders in promoting occupational well-being for an emerging diverse healthcare workforce ecosystem. I forgot to introduce myself. I am Vicki Good, Chief Clinical Officer for the American Association of Critical Care Nurses, and I am going to facilitate this session. This session is going to consist of 3 different presentations, one from Johns Hopkins, consisting of Dr. Carolyn Kumster Fowler, who's the Senior Director for Nursing Wellbeing, Dr. Sharita Hill Golden, who is the Hugh P. McCormick Family Professor of Endocrinology and Metabolism. Next, we will hear from Ochsner Health with Dr. Nigel Gurgraw, who is the Chief Wellness Officer there. Dr. Deborah Grimes, who is the Vice President and Chief Diversity, Equity, and Inclusion Officer. And then lastly, we will hear from UC Davis School of Medicine, Dr. Tanya Fancher, who is the Associate Dean for Workforce Innovation, Education, Quality Improvement Director in the Center of a Diverse Healthcare Workforce, and Dr. Mark Henderson, who is the Associate Dean for Admissions and Outreach. So first, I would like to turn it over to Johns Hopkins and Dr. Kumster Fowler and Dr. Golden.
All right, good afternoon, and happy to start off this session. Carolyn and I are going to tag team because our 2 offices have worked very closely together during my tenure and really share how we've collaborated. So I thought it would be helpful just to start off with providing an overview of the structure of our Office of Diversity, Inclusion, and Health Equity, because then that will frame how we've worked closely together with the Office of Wellbeing. So we really have focused on 3 strategic areas: workforce equity, health equity, and also culture and inclusion. And then you can see that for other D&I functions, we've also collaborated with our colleagues in community engagement as well as the business function areas of our organization. But it's around workforce equity and culture that we've collaborated most closely with the Office of Wellbeing. So one of the areas that we focused on in particular with regard to workforce is equitable and inclusive workforce policy. And I'm showing the 2 program directors who have really led that work. So we heard earlier, it was alluded to, that there is a lot of violence in the workplace toward our healthcare workforce. So one of the first policies that we helped to write and implement was a prohibiting discrimination and discriminatory aggression by patients and healthcare decision makers and visitors against JHM community members policy. And I appreciate that that's a mouthful, but we really wanted to make it clear that as an organization we wouldn't tolerate inappropriate, nasty, and really oppressive things being said to those who are trying to deliver care. So this covers physicians, nurses, environmental service workers, students, whoever interacts with our patients, as well as their visitors. We also worked with Human Resources to update our appearance policy to specifically call out religious headdresses, afros, braids, and locks as professional, really aligning with the Maryland and the U.S. Crown Act, so that it wasn't up to a manager to determine whether or not someone's particular hairstyle was professional. And then our LGBTQ plus equity and education program director really helped to champion a system-wide ID badge policy that allows our employees to use their preferred or chosen name. There are many reasons that someone would use a preferred or chosen name other than being transgender, so we had to really educate the organization that there are multiple reasons. She is also undergoing a review of our uniform policies to ensure that they're gender neutral. And also earlier this year, we implemented gender affirming transitioning in the workplace policy that provides guidance to employees as well as supervisors and managers about how to support an employee who's going through a gender transition in the workplace. So, in addition to the workforce equity, we have also focused on culture and inclusion within our organization. And so we have implemented several employee resource groups. So when I came into my role in 2019, there were 3 employee resource groups. Now we have 7. And these are really created to provide support, networking opportunities, a sense of community for employees who belong to specific groups. I should say that they also include allies, so are not exclusive to those groups. I think I'm a member of all of the ERGs that we have, and they often work to foster a more inclusive workplace and are typically, as I mentioned, open to all employees. So you can see the list here of the various ERGs that we've launched across our system. And so just in terms of how they are structured, the system level employee resource groups have an executive sponsor at the VP level or above that can really bring issues to the senior leadership that employees are experiencing, as well as ERG co-chairs, and they focus on community engagement, workforce culture and engagement, and there's also a communications manager. And I think that where our greatest intersection has come with the Office of Wellbeing is around the workforce and culture engagement piece, where that subcommittee really focuses on the Heritage Month recognitions, which include a focus not just on culture, but on education, leadership, and scholarship among those who really represent those diverse communities. So now I will transition to Carolyn.
Thank you, Sharita. Thank you. Hello, everyone. Delighted to be here. And on behalf of Lee Biddison, who is doing some well-being work of her own in her family. So, in the interest of time, I'm not going to introduce you to the structure of the Office of Wellbeing, but really I want to focus on where we've intersected. So as much as our office uses the NAM model as our guiding principle for all the work we do, in terms of sort of structural approaches, when we were working with the Office of Diversity, Equity, and Inclusion, we've really been using the Surgeon General's workplace mental health and well-being model, and specifically we think that our work is around belonging. So overarchingly, we're talking about belonging, but specifically if we think about 2 of the opportunities, one is in the area that is highlighted of protection from harm, and the second is that idea of creating connection and community. And for those of you who are not familiar with this document, let me just show you. So protection from harm includes those 4. I don't need to read slides to you. I think we're all pretty literate. But essentially, it's about this idea of physical and psychological safety as well as the idea of DEI and A norms. The other thing we've been working on is the destigmatization of access to mental health. So looking at our HR policies, looking at our credentialing policies, that's work that Lee is leading, and then the issue of mandatory breaks. But then the other area is the idea of connection and community, that idea of what does real inclusion and belonging look like, because that sense of the fact that I belong in my community, the fact that I feel meaningfully connected to my community, and that I feel that they will support me independent of who I am, that is the single biggest driver of resiliency. And so that's where we have huge connection between our 2 offices. And I'd like to say something about an obsession that Sharita knows that I have. And that is that, we don't do sort of yoga and spinach, right? We have to do something that's sort of systemic. And I'll give you a little bit about the history of this. So back in the beginning of the pandemic, we started launching some crisis leadership training that was built on the premise of psychological safety and psychological first aid. And as part of that work, instead of death by, mandatory learning, we decided to offer it in the form of a listening session, so that we presented the content and then I facilitated listening sessions, did this for 1,700 managers and leaders around the health system. And the thing that came up immediately, we launched in July of 2020, was the COVID is no longer the issue for us. What we are dealing with is co-occurring pandemics. We have a pandemic of racial inequity, of institutionalized violence against certain members of our community. We have the pandemic, and then we have this third recognition of just the psychosocial inequity of our workforce. People who are afraid for their children, people who are afraid in terms of their income. And so what I heard from these 1,700 leaders was not about what they wanted to do tactically. What I heard was, how do you support me in becoming a better listener? Because I feel like my new full-time job is listening and I've had no training for it. All our leadership competencies around communication are about talking and writing and speaking. None of them are about listening. And so in nursing, we started to do listening facilitation training, listening sessions with frontline and leaders. And the thing that I heard most about those was, we don't want to hear from you another time. They weren't actually saying it from me. They were saying, we don't want to hear from leadership another time about us being in a safe space. You cannot tell me when I'm safe or not safe. And so as of about September of 2020, I stopped using the term safe, and we started talking about safe and brave spaces, and emphasizing the fact that the perception of safety is visceral, it's not cognitive. And so therefore, we have to create conditions in which people feel physically, psychologically, and emotionally safe, and where we welcome people to speak their truth and to disagree with us. So we've now been expanding this so that we've been sort of increasingly, we actually realized that it's really hard to facilitate listening, because we have our biases, we have our emotional triggers, we have our trauma, and so when we're listening, I'm a qualitative researcher by training as well as a nurse, but when we're listening, we're imposing our biases, and our trauma is coming into the conversations as well. And so that's the work that we've been doing. Enough of that. I wanted to talk about something we did together, which was also about listening. As we got out of the first year, we realized that we wanted to honor the experience. We were thinking about post-traumatic growth, and we wanted to honor our pandemic experiences, not the COVID experience, everything that happened during that pandemic year. And so we pulled together our mental, emotional, spiritual health partners, Office of Wellbeing, and a lot of creative and diverse partners around arts and health and so on. And we worked with Sharita's office as part of that, and Sharita's going to tell you about one of the things we did.
Right, so we launched the Office of Wellbeing launched the Hope Initiative in March of 2022, and one of the things that we did, we realized that, well, for our office, that was also Women's History Month, so how could we do something that's centered on well-being and Women's History Month? So Marita Golden is an author, actually local to Washington, D.C., and she wrote this book called The Strong Black Woman, which really talks about how oftentimes, because women, particularly Black women, feel like they need to sort of be strong for everyone else, that they may neglect their own health and well-being. And I remember reading this book as a Black woman, and I said, well, golly, my white sisters have the same issue. And we thought, why not, as a part of that Hope Launch Month, have Marita lead a workshop on the importance of, she called it like how to get to saying no. To set boundaries, and this was particularly for a lot of our female workforce during Women's History Month. So that was the first program, but then the second one she did in April, because this was a series that we did, our offices did together, was around, and this was open to everyone, was really focused on how do we begin to write about our pandemic experiences as a way of healing. And it was really powerful because people began to share, and this was on Zoom, people began to share some very deep and personal things that were really helpful to them in beginning the journey of healing. So we don't have time to talk about it, but we have subsequently had Marita Golden do other workshops with our two offices around these writing exercises to really deal with the emotional issues that our workforce needs to heal. And I probably should say a disclaimer that Marita Golden and I are not related, and we really checked everything. She's not from Georgia, which is where my husband's family's from, but she's been a really great partner in our joint work.
And as a result of the work we did with Marita Golden, we then, as an Office of Wellbeing, offered storytelling training throughout our health system so people could tell their stories in a way that was meaningful. And the last slide is simply to say, one of the commitments is that we amplify each other's voices. So we have a monthly Office of Wellbeing briefing that goes out, and we intentionally integrate each month the issues that the Office of Diversity, Equity, and Inclusion are focusing on. So that's it. Thank you. I think that's
Hello. Hi, my name is Nigel Giragram. I'm a practicing transplant physician at Ochsner Health and Chief Wellness Officer, and joined with our fabulous Chief Diversity Officer, Deb Grimes, who I think wanted me to correct the audience that she's both a JD and an RN, but not a physician, and she's been with our organization since a week before the pandemic. And we're excited to tell you about a few of the things that we're doing in the diversity, equity, and inclusion space, some of the efforts and how they're aligning with our workforce well-being efforts. Just a quick slide about Ochsner. Ochsner is a non-for-profit health system that's based in the Gulf South, headquartered in New Orleans. We have 38,000 fabulous employees. We have about 4,800 employed or affiliated physicians and APPs who practice at 46 specialty hospitals and 370 health centers and urgent care centers. Cared for about 1.5 million unique patients last year, 4.7 million clinic visits last year, and patients saw over 90 medical specialties and subspecialties. So I assumed my role as Chief Wellness Officer in November of 2018 and spent most of 2019 working with Ashton Sloan, who's in the audience, and a few others to sort of stand up the Office of Professional Wellbeing. What you see here is our sort of strategy wheel that currently exists in 2024, our 5 strategic areas of focus. And I will say that both our scope and our strategy has evolved significantly over the past 5 years. So pre-pandemic, our scope was narrowly focused on our employed physicians and APPs, and we were sort of living in the bottom of the wheel, at the bottom of the wheel. Not that resilience wasn't important, but I wanted to send a message that we were intent on addressing systems issues and redesigning the coal mine. So our original stab at a strategy pre-pandemic was around promoting an organizational culture of well-being, working on practice efficiency, either with experimenting with advanced team-based care models or using technology. And we've heard earlier today the importance of leadership, not just senior executive leadership, but our physician chairs, our APP leaders, our emerging leaders in the organization, and even this idea that our patient-facing clinicians are all considered leaders in their healthcare delivery teams. So a couple of things became very evident. A few people made comments about this early in the pandemic, is that you could not look at one segment of the healthcare delivery ecosystem in isolation, right? It became obvious that our nurses, our pharmacists, our MAs were critical in supporting the well-being of not just our patients, but our physicians and APPs. And it also became clear that we, in many ways, because some of the efforts at the bottom of the wheel became paralyzed early in the pandemic, we had to focus on individual resilience, experimenting with different programs, and then looking at ways that we could support the mental health needs of our workforce, thinking outside the box, getting upstream from our traditional EAP programs, and obviously normalizing or destigmatizing the subject of mental health. I'm going to turn over the next 2 slides to Deb Grimes, if she can come off mute.
Thank you so much, Dr. Gigerith. I really appreciate the opportunity to sort of share at a high level our Ochsner Health Diversity, Equity, and Inclusion vision and some of the pillars that we prioritize. You know, just from a vision standpoint, we thought that words really do matter. And we wanted to just always articulate why we do this work. We really believe that diversity and inclusion provides a synergy that really celebrates individual uniquenesses among people, cultures, and structures, and that we always want to lead with collaboration that really empowers the entire Ochsner team to drive innovation and excellent outcomes, all while being culturally aware. And we focus all of our efforts to our core values of patients first, inclusivity, compassion, integrity, and excellence. And so when we started to think about how are we going to prioritize our work, the first thing came to our mind is we really wanted to provide culturally aware and equitable care. And we identified ways that we could do that. And I'm really happy to say over the 3 years, we started with a health disparities task force, and we now have a health equity center that's in collaboration with Xavier University, which is an HBCU located in New Orleans. And we have done a lot of things through OxyHer, that health equity center. But one of the things I'm really excited about is that we have announced that we're going to have in partnership a new HBCU medical school. Because when you think about what is the biggest thing you could do to address health equity, it's really to have more BIPOC doctors. And so we're really excited about, we just reached an agreement to do so last week. And those are the types of initiatives that the Health Equity Center, through this partnership, have been able to lead. And we also have metrics identified with this work, and we continue to monitor our outcomes from a demographic perspective. We are always looking at our policies to make sure that they are addressing equity. The second pillar is centered around creating a diverse and inclusive leadership, because we know that disparities will continue to exist until we have a workforce and we have a leadership team that better reflects our communities that we're serving. And so we had to look at how we are recruiting, how we're promoting, and the retention of all of our employees in our leadership group. We also knew that we needed to do bias training. We needed to educate people on the need for equity. And we really created a three-prong approach. And to date, we've had about 29,000 employees to self-select. It was not mandated, because we really wanted to address a level of engagement and commitment. And we were really excited that that many employees decided to go on this journey with us. And then the third pillar is, if you hire a bunch of diverse people and you do not create a space that's an inclusive environment, that's an environment where people feel seen and heard, and psychological safety is addressed, you don't have a comprehensive approach. And so we through our educational efforts, through having employee resource groups, we have 10 employee resource groups, one for our African American employees, one for our women, one for our Asian employees, one for our LGBTQ plus employees. We have one for our Hispanic employees. We also have some generational ORGs for our young professionals and for our experienced professionals. We have an employee resource group for employees with disabilities, for veterans. And I always say, if we do not have an employee resource group that represents you, come talk to me and we'll create one. And I really encourage people who do not self-identify, it is not exclusive, it's inclusive. And this is really a way that you can diversify your life intentionally, because so many times life gets in the way. And even though we're committed to diversity, we're limited in creating a diverse space where that you can have conversations with people that are different than you. We have over 7,000 employees who have actively joined our employee resource groups, and that number continues to grow. And I'm really excited that our entire executive team is sponsoring these ORGs. They are the executive sponsor, and they have committed to doing so. And we meet regularly to renew that commitment and just to talk about how they are removing barriers. And addressing issues throughout that process. The fourth pillar is our supplier diversity, because we believe in making an economic impact in our communities. And we have a very strong commitment to doing so. And to date, we've had about a 50% increase in our BIPOC supplier spend. So we believe it's very effective, this process of what we're doing. And then the final pillar is really centered around creating an effective communication strategy, internally and externally. Because if you're doing all this work, nobody knows about it, you're not doing enough to create a space of awareness. And also, you're not doing enough to create a space for partnerships. So we have a very comprehensive communication strategy centered around our work and being transparent about our metrics. Next slide, please. So, I really do believe if you want to get the outcomes, if you want to have great outcomes in this space, you have to have a great structure and a great process. And the way that we're able to do this work is we do have a system diversity, equity, and inclusion council that is chaired by the CEO of the organization and myself. And we set the strategic initiatives, we review the goals, we decide what we want to prioritize year over year. And then we have regional diversity councils that's chaired by our regional CEOs, partnered with one of our regional diversity directors. And that was really important because we just didn't want to have a executive commitment. We wanted to make sure that this strategy was implemented throughout the organization. We also have a physician and APP diversity council. We have an ancillary diversity council for respiratory therapy, pharmacy, lab, all of those ancillary services, environmental services, food and nutrition. All of those leaders, they wanted to participate in this process also. We have a nursing diversity council, and then we have our ORG leadership council. And all of those members attend our council as well. So I just wanted to demonstrate that at any given moment, there are thousands of people that are committed to this work throughout our organization. Next slide, please.
Yeah, we'll just really briefly hit on these next three slides and hand it over to our colleagues. But I think one example of the intersection is with our Mental Health Diplomats program, which is a combination of education and peer support. It lives within our Exceptional Abilities ORG. We've trained 84 employees in mental health first aid, which is a skill-based program that teaches participants how to recognize and respond to symptoms of mental health distress. And they've worked with about 200 employees to participate in these peer support groups. And you can see that we have 3 peer support groups, one for our employees that have been touched by anxiety and depression, those employees who may be caring for a parent or a child with mental health issues, and those that have dealt with grief and support. Deb?
Yeah, and this is just an example of how our work really intersects well with one another. One of the things our WOW, which is Women Empowering Women, focused on, we had a subcommittee, and it was really the stress of women entering back into the workplace after they have children. It's called the New Mom Meeting. And this just gets rave reviews from so many women in our organization, because you're paired with a woman who has done this multiple times, and maybe a new mom, and just sharing those tips. And we created a support group for the new moms and new moms of all ages, and we provided resources, and they're able to navigate the benefits process and re-entering back into the workplace. And this they have a Teams channel where they can chat and work with one another. So this is one of our biggest hits in our ORG land. Next slide, please.
Yeah, 30 seconds on this. This is our last slide. One of the things I heard when I did focus groups preparing for my role was, for some it was mysterious how leaders were selected, or it seemed unfair. So we've been very intentional about setting up a structure where we can expose individuals who are interested in leadership and give them an opportunity to sort of learn about what's involved, the soft skills and the hard skills around leadership. And I will pass it on to
me?
Yeah.
All right. Thank you very much. I'm going to ask everyone to pivot your brain a little bit to now really think about medical school. And Mark and I will share with you the work that we observed 20 years ago when we started at Davis, that patients who were underfunded, like our families, were not getting the same type of care as everyone else in the health system. And that really motivated us to make changes in access to care. We really emphasized primary care. And we saw that the residents that were coming to our program were increasingly diverse. We had much more language concordance for our patients, much more racial and ethnic concordance for our patients, which made us say, you know what, we should probably do this at the medical school as well. And this is all in the context of California having banned affirmative action in admissions and hiring about 30 years ago. So you may know that medical schools have massively expanded over the past 2 decades, both for MD schools as well as DO schools. There are far more positions for medical students. And when you look at the numbers for racial and ethnic diversity, although the numbers look higher, they're actually lower compared to the racial and ethnic diversity of the US. So even though we have more spots, we are really failing in this domain. And it's really important for us to think about not just racial and ethnic diversity, but economic diversity. This is a huge problem in the physician workforce. So this data comes from the AAMC, and the colors denote the family income of medical students across the US. So this is by quartile and quintile. And what it tells you is that 50% of medical students come from the top 20% of family income in the US. And what has not changed over time is that less than 5% of the students come from the lowest quintile of income. So medicine has really become and is an institution of wealthy families. And when we look at the data now, we see that low-income students are about half as likely to get into medical school, which is a profound crime. This student, it's not their fault that they're low income, right? It has nothing to do with their capacity, their passion, or their ability, yet we are holding it against them when it comes to admission to medical school. And that the economic piece is true regardless of race. So in California, we really talk about what is our mission for our state. We are a big public institution. Our mission is really to create the physicians for everyone in our region. That means regardless of means. And so we have really thought about this as how can we do this in the context of a ban on affirmative action. And our focus has really been on this poverty piece and how do we really look at those students with a new lens, those students who come from lower income. So I showed you the distribution of family income for US students. This is the distribution of family income for UC Davis students. And you can see that that lowest income red bar is much higher than 5%, and that the highest income gray bars is much less than 50% compared to the nation. And now, Mark, you ready? You're on.
Thanks a lot for the opportunity. I think one of the things that occurred, and maybe a little more context, is the affirmative action ban was put in place in 1998 in California. So this has happened in many other states, actually, in the early 2000s, where those types of bans resulted in declining representation of race and ethnicity across higher education. So this slide depicts the percentage of students from underrepresented groups entering our medical school beginning in 2000. And Tanya and I began to work on this together in earnest in about 2005. So you can see in there's a slow, in this graph, there's a slow, steady increase in the percentage of underrepresented students entering our medical school, to the point where 2 years ago, actually, we became essentially a majority minority medical school, like many of the HBCUs alluded to earlier. Now, again, so the average enrollment of underrepresented groups has tripled during this time period, and that's despite the affirmative action ban, which in California is actually more strict than the affirmative action ban recently passed by the Supreme Court, because it applies to all public operations. Next. So our school's gotten a lot of attention for this since the ban of June 2023, the Supreme Court ban. You can see the title here is the medical school at UC Davis ranks applicants by the disadvantages they have faced. Could this work across America? Next. These are some of our students there that we're examining a patient, by the way. What we've done here is a model, what we call socially accountable admissions, which means starting with a mission. Tanya showed the slide, the social mission, LBJ's mission of the Great Society, et cetera. That is, you have to have a mission and you have to have it guide your practices. And so our mission at the admissions level, we state this, we put it everywhere, and we try to operate by it, to matriculate future physicians to address the diverse health workforce needs of our region. Our region is California. In order to do this, it takes committed and longitudinal leadership. And a lot of times this is missing from, people rotate academic medicine, people go here, they go there, there's a lot of turnover. So we've been lucky to have consistent leadership in this effort, and that's really what it takes, is the long game work. We incorporate diverse input, not from simply the usual people involved, like faculty, who are not very diverse, generally speaking, but it includes students, community members, patients. All those people are involved in our admissions process. We use a method called multiple mini interview because it's blinded to school, blinded to grades, blinded to test scores, things that we know bias are really stacked against those with less economic or educational opportunity. Our focus is on, do students connect with our mission? Are they going to serve the patients that Tanya alluded to who are not being served currently with the output of medical schools? We emphasize the lived experience of healthcare. I think Dr. Bullock alluded to this. Having lived experience of healthcare is pretty powerful. And while hard to measure, it makes a huge difference in the clinical environment. So we use need-based scholarships, not merit. I put merit in quotes there, scholarships, because they often are not based on merit. They're based on something else, like opportunity, wealth, and privilege. We have tons of partnerships with local institutions, community colleges, high schools, and other medical schools that share our mission. She showed the financial distribution of our students. You can see on the right-hand side of this slide, 45% of our students are the first in their family to graduate from college. That's the highest percentage in the United States. In the average, I think the average last year was 14% in U.S. medical schools. Next slide. How do we do this? I mean, besides the principles I just alluded to, you have to look at talent differently. So I like this metaphor. This is Brad Pitt, of course, it's Moneyball, which was the Oakland Athletics, early 2000s. They developed a new method, a new way of looking at talent. I liken this to a new lens or a new way to envision merit. At the time, their statisticians found that, the people they were choosing actually weren't allowing them to win baseball games. So they started to develop a different way to look at that talent in a way that did correlate to winning games. And I think this is a really good analogy to what medical schools do, because if the game, winning it, means meeting society's needs, we're not doing well. And we're actually looking at the wrong things. And I've listed some of the things on this slide that I think are, again, influenced by mostly privilege, opportunity, wealth, And they don't correlate to what we need in healthcare. We've developed our own tool, which is the Davis scale. I'm not going to talk about it, but basically it incorporates measures of socioeconomic disadvantage that we feel are markers for resilience, grit, et cetera, things that are important for future physicians, as well as the lived experiences I alluded to earlier. Next slide. Just as important as looking at your talent differently, once a student enters your environment, of course, you need to make them feel welcome. And in order to do that, we've developed a number of what we call inclusive pathway programs within our medical school. Each of these has a unique mission that has to do with community health. So 30% of our students now are enrolled in one of these pathways. They're selected based on their experience, their personal and lived experience with the communities of need, as well as their aspirations to serve such communities. So the first one was a rural training program in 2000. Again, rural, how long have we been talking about the crisis of healthcare and the shortages in rural America? But how much are we doing about it? It's really hard, but the same with the primary care workforce shortage. We've been talking about it for decades. What are we really doing about it? These programs actually, again, attempt to connect those missions with students who have, again, a desire to be part of the solution to health needs in these areas. So we have an urban underserved track, a track that serves migrant farm working communities in the Central Valley of California. We have a 3-year primary care tract, and then our most recent pathway serves Native American tribal communities in California. Next. The outcomes of students that are in one of these pathways is very different from typical medical school outcomes. You can see on the left-hand side of the slide, 43% of the graduates of these programs go into family medicine or primary care internal medicine. That's 3 times the national average. They go into other specialties that are needed in California, and about half work in an underserved area, about a third practice in a rural area. Like 80% of these students come from underrepresented in medicine groups. Again, they mostly end up in specialties of need in our state. So they're meeting health workforce needs. Next. Just a couple examples. On the left-hand side of the slide, this is our 3-year MD program called ACE-PC, which takes students, mostly low-income students, 75% are underrepresented. They actually enter our medical school with lower grades and lower MCAT scores, but yet they go through faster than any other students. 85% of them have been successful and have gone into a primary care residency, and they are given a full tuition scholarship. So their debt burden is reduced because we know that's an impediment to people choosing primary care. Again, we've been doing this program for 10 years, and the outcomes are extremely impressive. Again, it requires investment, but these are very different students. They all have direct experience of primary care in their past, and they're become great primary care physicians. The second program in the middle has to do with connecting students from community colleges who are typically left out of healthcare, and they're left out of medical schools, but have an extremely important contribution to make and come from extremely diverse backgrounds, racial and ethnically, as well as economically. So this program is a bridge between community college and UC Davis that allows, community colleges look a lot more like the United States than the big fancy universities. Next slide. That's the last slide. This is the Shawshank Redemption. So it takes a long time to make a dent, and it takes a slow, small hammer chipping away. It's taken so I think this kind of work can be discouraging. This has been alluded to earlier, but it's something that you have to keep going. You have to stay at it, and you have to keep when you're faced with a hurdle, you got to keep going. So it's been a long effort. I think it's been very fruitful. There's still a long way to go, but the work is slow and it's worth it. Next slide. I guess that's the last slide. Thank you.
Thank you to all 3 of the facilities that presented. You left me with a couple of different thoughts. One, some unique language that we haven't heard so far that really resonated with me. One, the pandemic of inequality. I don't think we've thought about it in that frame, and that certainly resonated. And then safety being visceral. The psychological safety has always meant a lot to me. I've done a fair amount of work in the patient safety arena. And that is so crucial in the work that we're doing. One question that I had, really probably much more for Hopkins and Ochsner, although I think there's going to be a lot of people that are going to want to see the Davis score, because that work is fascinating. Having a son entering medical school shortly, I've seen those biases in med school applications, so very interested to see your formula there. But looking at the work that you guys are doing, how do you make sure that all coworkers within your facilities feel like this work is for them? What we see oftentimes, and what I saw having recently left the hospital setting, is a lot of times coworkers see this work as something dedicated for physicians and nurses only. And some of our other most crucial coworkers, our patient care assistants, our ancillary personnel, don't see this work as something for them. So what are some of the strategies you've used to make sure that everybody feels this work?
I'm happy to start with answering that, from the Hopkins perspective. I think one of the things that that we became clear to us is that our office needed to become the voice for those members of our community. So again, when I was starting, we were in the midst of the beginnings of the pandemic, and what became very clear is that everybody was centering the physicians and the bedside nurses in the pandemic, as they should have been. But at the same time, there was a shortage of PPE, and it was our environmental service workers who lived right in the zip codes around our hospitals, by the way, who were also having to clean those rooms, who were exposing themselves to COVID in a very direct way. So one of the things we did is we heard that. And I think a lot of times our employee resource groups, our Hopkins Diaspora, which is our African American employee resource group, they were sort of like our boots on the ground, and they were able to say, okay, these are the things that they don't have access to, and we made sure that we brought that to leadership, and that's been the way that we've then been able to draw them in. So when the vaccine rollout happened, we were going to roll out our vaccines by sending an email to tell people to sign up for the lottery. And, so again, our Hopkins Diaspora, and of course I knew this because I've been walking through the hospital for 30 years talking to environmental service workers. They aren't sitting by a computer. They are out there making sure that our patients are safe and cared for. So this was environmental services, dietary, public safety, facilities. So we had to come up with an entirely different vaccine rollout structure for them so that they could come to a table, in the lobby of the hospital, have somebody help them sign up. They assumed everybody was using MyChart. Surprise, surprise, everyone was not. So they could sign them up for MyChart, and then when their lottery number came up, tell them how to use it. And finally, I said, can we just have them call on a phone? Can we just resurface the dial phone so people can call and make their appointment? And so that's how we were able to engage them. So they began to see that the work included them, and that we became their voice. And so that's how we've been able to bridge that.
Yeah, and I'll be happy to share an Ochsner approach. I think the question is an excellent question, because when you do this work and you really highlight the benefit of doing the work, is really the patients that we serve. And so the natural focus is people will think this is for clinicians, for physicians, APPs, and nurses. And we intentionally structured all of our DE&I work to be inclusive of everyone. And we actually have a diversity council that it says anybody that's not a nurse or a doctor can join this council, because we wanted to be clear that we know that that the patients that we're serving depends on more than just physicians and APPs. Now, we do have a council for them, but we also have a council for environmental services, for dietary, for respiratory, for pharmacy, for radiology. And that committee is a joy to attend, because those individuals never felt seen. They never felt like they were special because they're behind the scenes, but try delivering care without environmental services, without lab and respiratory and pharmacy. It really is a team approach. And very similar to my Hopkins colleagues, out of that was birthed that it's not a one size fits all in how you communicate. We have made changes to our communication style. We communicate not just in English but in Spanish, because a lot of our environmental services and our food and nutrition, English is not their first language. And so we shifted how we approached. And then for during COVID, it was highlighted similar to you. Those individuals, they don't have access to computers a lot of times. That's not how they do their work. And so we collaborated with employee health, and we provided roaming services. We went to them, very similar to the community. We you know, when the vaccines came out, we went into communities. We set up mobile clinics so that barriers to getting to one of our facilities, that was not going to exist. We went in the communities where people needed the vaccine. We did a similar approach to our employees, and that worked very well for us to address some of the disparities that we were seeing. And then a commitment to ongoing listening. And we share with all of our groups, if you see something, say something. Even if you don't sit on the committee, we have open door policies. We do open formats. We do rounding just to informally go into the areas, which is a lot of fun. I learned a lot by just entering into the space of radiology, just walking around in scrubs sometimes, and it just alleviates those barriers. So we try to just, it's not a one size fits all, but we're committed to listening to all by a lot of different examples and ways to do that. We also have sort of the hotline premise that if you don't want to identify, if you want to be anonymous, we have a diversity.oshner that you can just we really don't care how we get the information, but we provide a variety of ways for people to reach us.
Thank you for that. Well, I think we could go on several more minutes on these discussions and learn more from these three different facilities, but we need to turn it over to move into our table discussion. So thank you for allowing me to facilitate from afar, and hopefully next year I can be there on site. Thank you.
All right, so we're in the home stretch. And on that note, maybe everybody could just stand up for a moment. It's been a long day. Just give yourself a nice stretch. You can do it visibly, you can do it mentally. Just check in with yourself. And when you're ready, grab a seat. So my name is Javid Sakara. It's an honor to be here with you today. I am the Chair and Chief of Psychiatry at the Institute of Living in Hartford Hospital. The Institute of Living is 200 years old. It was the birthplace of moral treatment, which is the idea of humane and dignified care for people with mental illness in the country. It's celebrating our 200th anniversary, one of the first mental health centers in the country. And I am honored to be here in particular because I've been a member of the Action Collaborative for the past 7 years. Over the past 7 years, I've had a lot of my own personal experiences, and I want to start off and share a little bit of a story before we kick into the discussions. And that story really speaks to, in the past 7 years, some of the trauma that I can speak to that I have endured with my family in relation to discrimination, hate crimes, identity-based violence. And I think that the piece of this that really speaks to me is the piece that I see through the eyes of my kids. So I have a Muslim faith background. My family is Canadian American. I moved from Canada to the US, which, come November is something, it's going to feel very strange. But when I look at my kids and particularly help them navigate the world that we're in, the challenge for me as a parent is to make them aware and attuned about the stereotypes that exist about them, but also to help them refuse to internalize those stereotypes and refuse to carry the weight of those stereotypes on their shoulders and refuse to have to overcompensate for their worth. So part of what's great about my role currently is that what we're trying to do at the Institute of Living is create a new center for research on racial trauma and community healing. And the reason I'm sharing this is because when we think about what we're hearing today, the idea of frameworks, we have to remember that the wounds of identity-based discrimination cut deep. But there's different kinds of pain. There's a scholar on racial trauma, Dr. Resma Menachem, who describes that there's a dirty pain and a clean pain. The dirty pain is the pain of resentment. It's the pain of this was done to me. And it's very alluring. It draws us in. And then there's a clean pain, which is the pain of transcendence and growth. There's a group of amazing Afrocentric and liberation psychologists who came up with a framework that's called the Radical Healing Framework. And this framework is anchored on a few things. It's anchored on things like critical consciousness, strength and resistance. It's anchored on radical hope. We heard this earlier from Dr. Malone. Hope has to be part of the formula. But it's also anchored on collectivism and community, because none of us were meant to carry this weight alone. But the part of the framework that really draws me in is that we have to practice active cultural authenticity and self-knowledge. We are the authors of our own story. We get to decide what that story will be about. So as we shift to our table discussions, I won't get too deep on you. We are going to be asking questions, if we could go to the next slide, about where we go from here. What's the action that we take? How do we co-write the next chapter in the history of this work, in the history of this country? And the question is about how do we embed change at an organizational level, wherever we're at, whatever we're doing? How do we embed it in human resources, access, flexibility, policy, codes, professional norms, partnerships, conflict resolution, recruitment, retention? How do we embed it in data? And not just about the data that we're collecting, but how we're disaggregating it, the kinds of questions we're asking. Who owns the data? Issues of trust versus mistrust. And how do we embed this change in governance, engagement, co-designing change, and accountability? So we have some time. I know folks have low energy. I know I do. However, this is an important conversation. So let's take some time at your tables to discuss how you can see a path forward, and then we'll open it up to a large group discussion.